Just want to call the Health and Workers' Compensation Subcommittee of the Insurance and Labor Committee to order. We are hearing one bill today, Senate Bill 82 by Senator Al, the 48th, and so we have those in our folder. We have Senator Sims here. Thank you, Senator Kirkpatrick, and hopefully Senator Robertson is on his way. And without further ado, Senator Al, you're welcome to sit there. Seems like you're camped out there, so that sounds great. And rather than the podium, and looks like we do have one person who signed up. And I understand we have a couple online, maybe Zooming. Okay. Okay. So you want to just present your bill? It's not a long bill. It's a great bill. It's your first bill. So in subcommittee, we won't give you a hard time, but I'm sure somewhere along the line you may get that. But here we are. We have a substitute to Senate Bill 82, LC 46039-1S. The floor is yours on mic 12.
Thank you, Mr. Chairman. So thank you so much for meeting so early on this foggy morning. I'm just going to walk you through the details of this bill. Many of you already understand the scope of the issue that we are trying to address and actually have read through this bill pretty carefully already. But just for the record, so we can all be on the same page. There is a substitution to this bill from the original. It's a very minor substitution that's essentially just a scrivener's error, and I'll just point out where it is in case you guys don't have to flip through the whole thing, is that line 58 originally on the original draft of the bill, they had written the word disposition, and we had just changed it to diagnosis, that word, so it was consistent throughout. So this bill essentially seeks to clarify the OCGA code related to insurance coverage of emergency medical care, and adding on language that if a patient seeks emergency medical care for reasons that meet the prudent layperson standard, that this care should be covered regardless of that patient's final diagnosis. And I'm going to explain a little bit about what I mean in a second. Just to give people some context, I've passed out some packets that you should all have in front of you. It includes the final report of a Georgia House study committee that was tasked in 2018 with studying this exact issue, and they did a very good job of doing that research. And also 2 lay press articles relating to this issue. So just about the research. In 2018, the Georgia House created this study committee looking into the phenomenon of retroactive denials of claims received for emergency room care. The study committee was formed in response to a policy that Blue Cross Blue Shield implemented in 2017, and that got some traction in the press. Essentially, policyholders, people who have health insurance, are now being forced to self-evaluate before making a trip to the emergency room to make an assessment of whether their medical condition is truly a real emergency or not. And if, after the emergency room visit, the insurance company determines that their symptoms didn't justify a visit to the ER, then their claims would be denied. And just to frame this in real-world terms, I want to give a few examples of testimony from that House report from patients, just so you can see exactly what we're talking about. If you open your hymnals to the study committee, patient number 1 in this was a 64-year-old female who was involved in a motor vehicle accident and came to the ER complaining of very severe neck pain. On ER presentation, she had an abnormal exam and received imaging studies, which ultimately did not show a fracture, but was worked up. She was diagnosed for neck strain, and payment was denied because services were deemed not medically necessary. Patient number 4 in this research study was a 52-year-old woman who had increasing chest pain and shortness of breath. She did have a history of angina, which is cardiac-related chest pain, and had been recently admitted to the hospital for heart disease. So she went to the ER, was stabilized, and transferred to a doctor's care for further stabilization and treatment. This ER visit was also on a weekend. This payment was also denied, services deemed unnecessary. And just one third case, just to give the full scope. 50-year-old woman come to the ER in the early morning complaining of domestic abuse and arm pain. She was diagnosed and treated for a fractured wrist, and a police report was made. She was discharged. Blue Cross Blue Shield denied this payment, services deemed not necessary. So in addition to Georgia, this problem is seen in some other states too, including Indiana, Kentucky, Missouri, New Hampshire, and Ohio. Just before we dive into some specifics, let's talk about what this prudent layperson standard is that underlies this case. So one of the most crucial laws behind medical patient protection is this prudent layperson standard, which requires insurers to cover services where, and this is the language they use, where a rational person without professional or specialized knowledge in medicine would believe their condition to be one of many medical conditions. Neither a government or the courts have the authority to determine what a prudent layperson is to the insurance companies. And the skill set of an emergency physician, as many of us know, is to identify and evaluate possibly dangerous symptoms, work them up, and treat them when they're found, and then provide reassurance if they're thankfully determined to not be life-threatening ultimately. And I'm just going to say this as someone who's worked in the emergency rooms. Lots of times when patients come to us with these symptoms, even the medical staff cannot immediately determine just from the description or from the vital signs what is a life-threatening emergency or not. And in fact, many patients are told to go to the ER in the first place by their physicians to allow medical professionals who are adept at this to do the workup and make those determinations. Now, to be clear, and just to argue the other side, no one is proposing that patients should go to the emergency room for frivolous reasons, right? No one's saying that you should go if you have seasonal allergies or if you have a hangnail. These are not good reasons to go to the ER, and we understand that. That's what the prudent layperson standard, in fact, delineates. And some conditions are really better treated in an outpatient setting. However, in the House's study, many cases were identified that did in fact meet Anthem Blue Cross's standard for coverage, including patients who were told to go to the ER by other physicians and still had their claims denied. So what this bill ultimately seeks to do is protect patients from these unfair charges by closing a loophole in the current insurance code. So in closing, there's just two harms incurred when insurance companies deny claims, and this is what we're trying to avoid. This is the harm we're trying to avert. The first harm is obviously that patients are unfairly burdened with the debilitating cost of their care. The second harm is that patients hearing about this phenomenon in the news, you see it's in the newspapers, we're talking about it right now, they hear about this thing and they hesitate maybe from seeking urgent medical care even when their symptoms warrant it because they're scared about having to shoulder these costs unfairly. And in the words of the House Committee report, quote, if illness and injuries are left undiscovered due to fear of using health insurance, then it would appear that policyholders do not have insurance coverage at all and would have been paying their premiums essentially for no service. So I'm happy to take any questions about that, and I also have two expert people to give testimony about this issue who've been working with it for quite some time. One is Dr. Chip Pettigrew, is the former president of GSEP, the Georgia College of Emergency Physicians, and one is a patient advocate specialist. Are
Great.
they, we'll
Thank
take
you,
questions
Dr.
first.
Al. If we could go ahead, you ready to key them up?
Sure.
Sounds good. Andrew, can you go ahead and...
I think we'll have,
Rick has another meeting
At 8:30.
at 8:30? All right, so we are at 8:15. So, Dr. Al, Senator Sims has a meeting
oh, okay.
at 8:30, so
This should be fast. I told them 2 minutes-ish.
2 minutes each?
Yeah.
Great, sounds
Is
good.
Diane on? I would like Diane to go first if she's, Dorothy, sorry, yeah. She's the patient advocate. I just want to present the patient side first. Thank you. Thank you. This should be short.
Good morning.
Good morning, Dr. Watson. Good to see you again. I'm here on behalf of the Advocates for Responsible Care. I am their executive director and the RX and Reach Georgia Coalition. We are 41 healthcare-centered members and medical professionals who advocate for access and affordability for patients for their prescription drugs and their medical care. The RX and Reach Georgia Coalition is in full support of HB 82. As 41 healthcare professionals, we really understand the nuances of this, and we ask that you consider the fact for many of us, this is our oath to do no harm and to ensure that all is done to help patients. Anything other than upholding this original standard places an unreasonable burden on the patients and on medical professionals. As caregivers, we follow through on all warning signs in medical emergencies, and we ensure that patients are being treated. Anyone who seeks emergency medical care suffering from symptoms that appear to be an emergency, as the doctor mentioned, chest pain, other conditions, cannot be denied coverage or expected to require a prior authorization, even if the final diagnosis does not turn out to be an emergency. I've been a nurse specialist for over 40 years, and I know in an emergency, every second counts, and many times it can be a matter of life and death.
Yes.
No one should hesitate to get the care that they need because of fear from a large medical bill or that their claim will be denied. The only relevant considerations are the patient's symptoms and whether a prudent layperson would think that that emergency medical attention is necessary based upon those symptoms.
Ms. Leon Glasser, thank you very much. We appreciate your testimony. Does anybody have any questions? I appreciate that. Thank you so much for being with us, and we have Dr. Pettigrew. We have your testimony, Ms. Glasser, in our packets, and we appreciate you being with us. Can we get Dr. Pettigrew is coming up? Thank you. And Dr. Pettigrew, we also have your testimony in our packets also. We appreciate that. And good to see you. The floor is yours.
Thank you, Chairman Watson. It's a privilege to speak on behalf of our patients from the perspective of the Georgia College of Emergency Physicians. I'm going to be fairly brief since you have my written testimony. I did submit an updated testimony a short while ago with some typos, which hopefully will be a substitute for the record. As you know, in 1996, the Georgia legislature adopted the federal prudent layperson standard, which defines emergency medical condition based on the decision of a prudent layperson with an average knowledge of medicine and health. And since that time, insurance have been chipping away at PLP protections. Georgia's insurers are denying payment for patients seen in hospital emergency departments who have been given diagnoses that an insurer considers based on their proprietary list to be non-emergent conditions. And this is being done every day in Georgia, and this is a clear violation of state and federal law. As you know, patients have endless examples of these denials, which are in various stages of appeals, incomplete payment, bad debt write-offs, and some of this has even gone to court in private action. And as you know, the Medical Association of Georgia and the American College of Emergency Physicians sued Anthem, Blue Cross Blue Shield, in federal district court in 2018. On follow-up of appeals based on standing pertinent comments by the U.S. Court of Appeals and returning the court back to federal district court. The U.S. Court of Appeals stated that the prudent layperson standard, which is based on an average person with an average knowledge of medicine and health, is what is paramount for payment and not the final diagnosis. We need our legislature to step in and clarify that an emergency medical condition is not based at some later time upon a final diagnosis.
Thank you. Thank you, Dr. Pettigrew. I really appreciate that. Does anybody have any questions from the committee for Dr. Pettigrew, or if we could go maybe to the bill? Thank you so much, Dr. Pettigrew. Anybody from the committee have any questions for Dr. Al? If not, I'm happy to entertain a motion. You're on number 14.
Okay, Mr. Chairman, I would move that we recommend to the full committee do pass for LC 460391S.
All right, do I hear a second? Second, so that was a motion for due pass by Dr. Kirkpatrick, and Senator Sims seconds the motion. All those in favor say aye. Aye. So it's unanimous, and thank you very much.
Thank you, everyone.
Meeting is adjourned.